Alright guys, welcome to Radiology 365, where we try to cover core radiology, a visual approach to diagnostic imaging. This is the second edition, from cover to cover. We are starting off from the first chapter, which is thoracic imaging, and we'll just dive right in with the introductory concepts. So starting off, we're going to start with the lung, lobar, and segmental anatomy. We already know that the right lung is divided into 3 lobes, and the left lung is divided into 2 lobes. Each lobe is divided into segments. The right lung, the right upper lobe is divided into 3 bronchopulmonary segments. The middle lobe is divided into 2 bronchopulmonary segments, and the lower lobe is divided into 5 bronchopulmonary segments. The left lung is divided into 2 lobes. The upper lobe has bronchopulmonary segments that kind of mirror the right lung, and then the lower lobe also has some bronchopulmonary segments that kind of mirror the left lung. There are minor differences which we would look at. So the right upper lobe has an apical posterior and an anterior segment. I like to remember this by considering the right upper lobe to be kind of a triangle that's oriented from front to back. So let's assume this is the front anterior, this is the back posterior, this is the top apical. Let me make it AP. So yeah, so we have an apical segment, posterior segment, and then an anterior segment, as you can see here. Then I like to also consider the right middle lobe to be a horizontal line, where we have a lateral segment and a medial segment. And finally, I'd like to consider the lower lobe to be like a pyramid. So we have a superior segment, and then we have our 4 basal segments. So this lateral, this medial, this is posterior, and this is anterior. So all these are basal segments. So lateral basal, medial basal, posterior basal, anterior basal, and then the superior segment. So by this, I try to remember the bronchopulmonary segments. And then when I come to the left, I just translate that same knowledge, but this time I make a few tweaks. So for the left side, all this is part of the upper lobe, just that. The apical and posterior are combined. The horizontal line is no longer a horizontal line, but this time a vertical line, and represents the lingula. So we either have a superior and inferior, and then the anterior and medial segments also combined. So that gives us an apical posterior segment, an anterior segment, a superior segment, an inferior segment for the lingula, which is the correspondent for the middle lobe of the right, and then a superior lateral basal, posterior basal, and anteromedial basal segment for the left lung. Then the next thing we'll talk about is the interlobar fissures. The interlobar fissures, the minor fissure separates the right upper lobe from the middle lobe. So this is the minor fissure, or the horizontal fissure, separates the right upper lobe from the middle lobe. And then the major fissure, or the oblique fissure, is separating the middle lobe from the lower lobe. Now, if you look at it, you would think that this should be the major fissure, and this should be the minor fissure, because this looks bigger than this one. But I think it's a correspondent of what's happening on the left side. If you look at the left side, this huge fissure, it's a big fissure, and it seems like it's the same thing that's going here. It's just that something just comes to truncate it. Hence, for the sake of consistency, I guess, this is the major fissure, this is the minor fissure, this is horizontal, sorry, oblique fissure separating the left lobe into an upper and a lower lobe. Now, if you look at the way the fissure is oriented, it tells us that a large chunk of the lower lobe, the left lower lobe, is actually very high up in the chest, and a large chunk of the right upper lobe is actually very low down in the chest. So if you look at the PA image, you can see that there's a lot of overlap going on. The right upper lobe covers a very large chunk of the chest from top to down. The same way behind it, part of the lower lobe actually is quite high up. And the same thing goes on the right side as well. You have a large part of the lower lobe superimposed posteriorly on what we are seeing here. And so on x-rays, it's better to rather use zonal anatomy, upper zone, middle zone, and lower zone, as opposed to seeing with your chest that there's a lesion or something in the upper lobe or the lower lobe. Of course, you would have to apply certain other techniques to differentiate middle lobe from upper lobe and lower lobe lesions. All right. Next, we'll look at some accessory fissures. Now, these accessory fissures are not present in every human being. They are anatomical variants. So we have, if you look in the right upper lobe here, there is this fissure that runs obliquely in the apex, which is actually what we call the azygos fissure. It's an accessory fissure and it's present in less than 1% of patients. And it basically creates what we call the azygos lobe. It's not a functional lobe, it's just present because of a kind of defect as the azygos vein truncated through the upper lobe and kind of creates this division. So it's not functionally a bronchopulmonary segment or a lobe. It can't act independently as a lobe on its own. Then we also have what we call the superior accessory fissure. It's seen in approximately 5% of patients, and it separates the superior and then the basal segments of the lower lobe. So here you can see that this is the right lower lobe, but then there is this other fissure that is separating the superior segment from the rest of it. So that's the superior accessory fissure. And then the inferior accessory fissure, seen in approximately 12% of patients, and it's more common in the right lung. It divides the medial basal segment. So if you look here, there's this fissure that runs here, if you are following my pointer, and separating the medial basal segment from the rest of the basal segments. All right. Then we'll now take a look at an overview of atelectasis. Atelectasis is basically a loss of lung volume due to decreased aeration. It's synonymous with lung collapse, and it may be caused by bronchial obstruction from mucus plugging or some external compression, maybe by some pleural effusion or pleural based lesion or something like that. Right. The main mechanisms of atelectasis include obstructive, relaxation, adhesive, and cicatricial. So obstructive atelectasis occurs when alveolar gas is absorbed by blood circulating through alveolar capillaries, but is not replaced by inspired air because there's some bronchial obstruction. So you have some obstruction, you have your alveolar, let's say this is your alveolus, you have something obstructing here. Let me shade it a little to make it look more solid. Yeah, so you have air in here, but the air is being absorbed into circulation. But because there is something obstructing here, air is unable to cross the obstruction to replace what is being absorbed, and therefore eventually you have your alveolus shriveling. Our obstruction is still there. Yeah, so that's obstructive atelectasis. Then with regards to relaxation atelectasis, it's atelectasis that's caused by a relaxation of lung adjacent to an intrathoracic lesion that's causing mass effects, such as maybe a pleural effusion or a pleural based lesion, a pneumothorax, pulmonary mass. So you have your pleura here, you have a lesion, here, and because of the presence of this lesion, the lung that should have been here is now squished and compressed right adjacent the lesion. It could be any lesion. It could be an effusion. It could be a hematoma. It could be a pneumothorax. It could be air. So it is that's displacing normal lung. It will squish it, and then it will cause some kind of compression. So that is relaxation atelectasis. Then adhesive atelectasis is when there's a deficiency in surfactant. So when a child is born preterm and there's no surfactants to keep the alveoli open, you'd have the walls of the alveolus collapsing on itself. So there should be some surfactant. By the absence of the surfactant, the walls collapse. Right. And the last one, cicatricial atelectasis, is volume loss from architectural distortion of lung parenchyma by fibrosis. There is reduction in the elasticity and compliance of the lung, and all those scar tissue within the lung just causes it to collapse. So that is for cicatricial atelectasis. So with the signs, what shows us on a radiograph that there is atelectasis? We have direct signs and we have indirect signs. So the direct signs of atelectasis are from lobar volume loss. So when the obvious loss of the lobe or a segment, these direct things would show us that the lung is collapsed. So you have displacement of the fissures that's happening directly to the lung parenchyma. So the fissures, for instance, I mean, we'll see a picture of this in the next slide. So then you may also see plate-like or triangular opacities. So when there is loss of air and the lung collapses, that actual collapsed lung itself would appear either plate-like or would appear like a triangular opacity or some opacity in the lung. So that's also a direct sign. Then you also have some vascular crowding. Let's say the vessels are spread out like that. That's why it does this. When the segment of lung is no longer as big as this and is now as small as that, the vessels that were spread out like that would now kind of crowd this small segments. So there's vascular crowding as well. All these are direct signs. Then with the indirect signs, you may have, so these are things that are happening outside the lung but still tell us that there is some loss of lung volume. So the indirect signs are due to the effect of volume loss on adjacent structures, and they include elevation of the diaphragm. So yes, makes sense that if there is volume loss, the diaphragm would rise. Rib crowding, similar to the vascular crowding, but since the ribs are not inside the lung, it joins the indirect signs. Then mediastinal shifts to the side, there's a loss of volume. Overinflation of the contralateral lobes, compensatory overinflation actually. And then you can also have the hilum being displaced. Lobar atelectasis is usually caused by central obstruction, central bronchial obstruction. So in order for you to have the whole lobe collapsing, it means that, let's assume this is a lung, it's a right lung, pardon my drawing. Let me run through upper, middle, and lower. Awesome. So in order to have the entire upper lobe collapsing, that means you must have something obstructing the main bronchus. such that there is no air going to the entire upper lobe, and so you'd have complete upper lobe collapse. And this may be secondary to mucus plugging or an obstructing neoplasm. Yeah, so if the lobar atelectasis occurs acutely, think more of mucus plugging. And it's actually most common in the lower lobes. It's least common in the upper lobe, especially the left upper lobe. It makes sense because of the action of gravity. So it's more lower lobe dependent. And there are certain appearances that are characteristic of lobar atelectasis, and it depends on which of the 5 lobes is collapsed, whether right upper, right middle, right lower, left upper, or left lower. So we are going to take a look at them next. All right, so let's take a look at these schematic diagrams and pay attention to the fissures and how they move during collapse. So this is the minor fissure, the right. So this is the right upper lobe. So this one, we are looking at this image in a sagittal. So this is the side, looking at the side of this image. So this is the right middle lobe, this is the right lower lobe. If the right upper lobe were to collapse, the minor fissure would rise. That's if the upper lobe were to collapse. The minor fissure would rise to join here, and then the oblique fissure would also rise. If the middle lobe were to collapse, the minor fissure would drop a little, and then the oblique fissure will also rise just to meet it there. If the lower lobe were to collapse, the major fissure would move in this direction and in that direction. So you have kind of basically think of overinflation of the adjacent lobes, right? So if the upper lobe were to collapse, the lower lobe and the middle lobe would inflate to fill the space. If this were to collapse, the upper lobe and then the lower lobe would inflate to fill the space. And if the lower lobe were to collapse, the upper lobe and the middle lobe would inflate to fill the loss of volume. So that's how you can remember the movement of the fissures. You don't have to chew it. Just understand that the adjacent lobes would inflate to fill the space. So for the left lobe, if the left upper lobe were to collapse, the left lower lobe would inflate, hence the fissure would move in this direction, and vice versa. Right, so just thinking about it in that way would help you remember the movement of the fissures. So let's start off with the appearances of left upper lobe atelectasis, the imaging findings of left upper lobe atelectasis. So with the left upper lobe atelectasis, you have the key imaging findings include a veil-like opacity on the frontal radiograph. You will also have anterior displacement of the major fissure and anterior collapsed lung on the lateral radiograph. There's also what we call the Luftsichel sign. That's air sickle. That's in German, Luftsichel, air sickle in German. And this sign is a crescent of air seen on the frontal radiograph, which represents the interface between the aorta and the hyperexpanded superior segment of the lower lobe. But you shouldn't expect to see this all the time. It's not always present. So let's dive to our image and see if we can see these things. So first and foremost, right off the bat, you can observe that the opacities of these two hemithoraces are not the same. The left hemithorax just appears slightly more opaque than the right hemithorax. That's the veil-like opacity we're talking about. Then if you look at the interface between the arch of the aorta, you can see some lucency here, a kind of a comma-shaped lucency separating the arch of the aorta from the veil-like opacity that is overlying the left hemithorax. So this comma-shaped air lucency is what we are calling the air sickle. That's the Luftsichel sign. Right. So you can actually see normal hyper expanded left lower lobe in this image, which has a normal lucency compared here. This is the normal lucency of normal lung, and then there is some opacity overlying it. This opacity goes all the way below. That is the collapsed left upper lobe. Then on the lateral image, as you can see, anterior displacement of the major fissure. So the major fissure should be moving this way. However, you can see that it's actually displaced anteriorly, so all the way here. And now there is this opacity in the anterior part of the left lung. So that tells us that there is a left upper lobe collapse. The next thing we'll talk about is the right upper lobe atelectasis. Its major imaging findings. So with right upper lobe atelectasis, the major imaging finding is the reverse S sign of Golding. So on the PA radiograph, we see this. If we were to trace, you can actually, let me see if I can try to trace. You can actually trace this. That kind of looks like an S drawn backwards, and this indicates that the upper lobe collapses usually as a result of a mediastinal mass. Not all the time, but it's usually as a result of a mediastinal mass compressing on the right upper lobe bronchus, and hence obstructing airflow into the upper lobe, and thus you have the right upper lobe collapsing. Now this also tells us that whereas the minor fissure should have been somewhere here, it's elevated to come all the way up here. So this is the minor fissure elevated up there, and then this curvature down here could represent the outline of the mediastinal mass as compression on the upper lobe bronchus. And then of course, not to mention the opacity, the triangular opacity in the upper lobe, right? On the lateral, you can see that the major and the minor fissure are elevated. And this is the triangular opacity that's used to represent the upper lobe. That represents the upper lobe. Yeah. With other signs, we have other signs that tell us that we have some upper lobe atelectasis, and there's something we call the juxtaphrenic peak sign, where phrenic is basically diaphragmatic, right? So this is the diaphragm, which should be a smooth curve. It should be a smooth curve. However, we have this peak that has come up here. So the juxtaphrenic peak sign is a peridiaphragmatic triangular opacity caused by diaphragmatic traction from an inferior accessory fissure or an inferior pulmonary ligament seen in upper lobe loss from any cause at all. So when you have, so it's not always present. It will only be present if you have an inferior accessory fissure or an inferior pulmonary ligament there. And so when you have loss of upper lobe, as you are seeing here, this bad upper lobe collapse, the loss of volume kind of pulls up, tense on the diaphragm, hence you have that tension. I mean, you can obviously see other signs like the tracheal deviation here, and then the elevation of the minor fissure, right? And the next one we'll talk about is the left lower lobe atelectasis. The major findings include a triangular retrocardiac opacity, and that's actually the main imaging feature. So you would see the normal cardiac outline, and then just behind the cardiac outline you have another linear opacity, triangular opacity there. Then for the right lower lobe collapse, I mean, we also see a triangular opacity, kind of similar to what we saw in the left lower lobe collapse, but this time it's on the other side of the heart. It's actually a mirror image of the left lower lobe atelectasis. So if you look at this image, you can see this is the outline of the heart, This is the normal outline of the heart, but then behind we have this other triangular opacity here, retrocardiac triangular opacity, indicating the right lower lobe collapse. Then for the middle lobe, the findings of right middle lobe atelectasis can be subtle on the frontal radiograph, but mainly look out for silhouetting of the right heart border by the collapsed medial segment of the middle lobe. So when you have, remember I mentioned we have the medial segment and then the lateral segment. If you have a complete lobar collapse, yes, you would have silhouetting of the right heart border where you can't clearly draw a line to show where the heart border ends. You are just seeing this opacity in the right lobe silhouetting the right heart border. It tells you that you should be thinking about a possible collapse or consolidation or something like that. Of course, consolidation would have air bronchograms as well. Also, if you have segmental collapse, something to think of. If you have lateral segmental collapse, such that the medial segment is not collapsed, but the lateral segment is collapsed, you will not have silhouetting because it is the medial segment that is directly adjacent the right heart border. But if you have a complete middle lobe collapse, yes, you would have silhouetting of the right heart. And then this is this classic appearance on a lateral, the classic appearance on the lateral. So just again to remind us of the schematic that we looked at, looking at the patterns of collapse and how the fissures move. A quick bonus, apart from the lobar atelectasis that we are speaking about, we also have something we call round atelectasis. It's a focal atelectasis which has a round morphology, and it's always associated with an adjacent pleural abnormality. That is either a pleural effusion or pleural thickening or pleural plaque or something like that. Round atelectasis is most common in the posterior lobes, and there are certain criteria that must be present for you to say or for you to confidently diagnose round atelectasis. The pathology has to be adjacent the pleura, so it has to be adjacent an abnormal pleura. Then the opacity must be peripheral and in contact with the pleura. The opacity must be round or elliptical. There should be some volume loss in the affected lobe, and the pulmonary vessels and bronchi leading into the opacity must be curved. So looking at this schematic, you can see that it looks like the lung, this is the normal lung parenchyma, but then when it gets here, it kind of like coiled on itself. The parenchyma has just coiled on itself there, and this can only happen when the adjacent pleura is pathologic in a way, either pleural effusion is there or pleural mass or pleural thickening or something, right? So in this CT image shows round atelectasis, and this is a non-contrast CT, shows a round opacity in the medial right lower lobe. Evident is being pointed to by these red arrows, and it meets the criteria, the 5 criteria around atelectasis, where we have an adjacent pleural abnormality, so there's some pleural effusion here. There's an opacity, the opacity is in direct contact with the pleura, with the pathologic pleura. It has a relatively rounded shape, and what we call the comet tail sign. That's the curved appearance of the pulmonary vessels and bronchi leading to the lesion. So if you look at these, they seem to kind of give the lesion, make the lesion appear to have a comet tail. That's what we call the comet tails, and a curved appearance of the pulmonary vessels and the bronchi leading to the lesion. So all these kind of are suggestive of a round atelectasis here. All right. Thank you very much for your attention. Next topic we'll be discussing will be patterns of lung disease. See you.